My name is Chris Wallace, and this is Fibrinolysis. The wood chipper is a prelude to the metaphor that we will be using throughout the talk. In order to fully understand fibrinolysis, we first have to talk about injury. An injury is a fact of life. Every time we go downtown and have a drink, our bodies sustain a little bit of injury. Every time we have a cheeseburger, our vessels, our GI tract sustains a little bit of injury. Every time we work out, our muscles, the vessels that supply those muscles, sustain a little bit more injury. Ultimately, by whatever cause, when we have injury, we have fibrin deposition. Thus, we can say that fibrin deposition is a fact of life. If we take a vessel, for example, and expose it to some of these daily damages that we incur, our vessel becomes injured. For the purpose of simplicity, we can represent that injury as a small cut on the vessel wall. This small cut leads to the deposition of a little bit of fibrin from the coagulation engine. If we don't have a mechanism for dealing with these small injuries, it can lead to something like this, a fully occlusive thrombus. But we've all had a cheeseburger, gone downtown, and work out, so why aren't we thrombosing every day? Because of the Woodchipper of Fibrinolysis, our mechanism of removing this fibrin. Like any wood chipper that takes in wood and spits out wood chips, our Woodchipper of Fibrinolysis takes in fibrin and spits out fibrin split products, what we know as D-dimer. Fibrinolysis is the mechanism that maintains homeostasis in our vessels to ensure that the injuries that we incur from daily living don't lead to thrombosis. The things that we need to know about fibrinolysis are how the system works, what actually grinds up the fibrin, what comes out the other end, and how we turn off the wood chipper. So first, let's take a look inside the chipper. Inside any wood chipper, there are teeth that grind up the wood. Thus, we need teeth to grind up the fibrin. And the teeth of this system are plasmin molecules. Plasmin is what grinds up the fibrin into fibrin split products. Plasmin is generated from its zymogen, plasminogen. And in order to fully understand this system, we need to know how plasminogen gets converted to plasmin. Much like the complexes of the coagulation system, there are complexes of the fibrinolytic system. So let's take a look at our endothelial surface and see what the complexes of fibrinolysis are made of. First, we have plasminogen. We have to have something that gets activated to plasmin, and that is plasminogen. Next, we have TPA, which is the enzyme that actually activates plasminogen into plasmin. Next, we need something that holds these two molecules together to increase the rate of the reaction. We need a Velcro. And our Velcro in this system is fibrin. Fibrin is made of many monomers that form long polymeric strands, which we can represent as this red line. On this fibrin is Velcro, which acts as little hooks that grab onto plasminogen and TPA. In reality, this Velcro is made up of lysine residues that, when you look at their structure, looks like little hooks that grabs onto the plasminogen and TPA. Thus, these are our complex components. Plasminogen, TPA, our activator, and fibrin, our Velcro that holds these all together. So let's see how this reaction plays out on an endothelial surface in the setting of injury. We have damaged tissue secondary to our injuries of daily living, and ultimately the coagulation engine lays down a fibrin meshwork to prevent us from bleeding out. When the engine has stopped running and halted the bleeding, we need to remove the fibrin to prevent its buildup, to prevent thrombosis. So we have plasminogen in the circulation that locates to our fibrin velcro on the endothelial surface. We have, at the same time, we have TPA that is released from the endothelium and also locates to the fibrin velcro. Since TPA and plasminogen are in close proximity, the conversion to plasmin occurs at a rapid rate. Plasmin can ultimately cleave fibrin. Because fibrin is both the velcro that allows for this reaction to occur at a high rate and the product of the coagulation engine that is being broken down by plasmin, we can say that fibrin signals its own demise. We have been talking about how exercise is a source of daily injury that leads to fibrin deposition that could potentially build up into a thrombus if we don't have a fibrinolytic system. Well, we all work out, so where do we see the benefits? We see the benefits in TPA. Every time we exercise, we see an increase in TPA secretion from our endothelium. If we take a look at this chart that has TPA activity on the y-axis and time post-exercise on the x-axis, we can see that immediately after exercise, TPA activity increases tenfold. When comparing people with a sedentary lifestyle to those people who have an active lifestyle, their fibrinolytic capacity or baseline TPA levels are dramatically different. We can say that people who exercise have a more powerful wood chipper compared to those who do not. So these are the same benefits of fibrinolysis extended to the long term. So now that we've seen what goes on inside the wood chipper, we need to shift our focus and see what comes out the other end. In order to understand what comes out the other end of this wood chipper, we need to take a closer look at the structure of fibrin. Fibrin is made up of multiple cross-linkages between D and E domains. Plasmin will ultimately cleave fibrin at specific locations, resulting in specific products, particularly D-dimer. We all know that D-dimer is useful for certain clinical tests, but how does this fit into the fibrinolytic system? It's useful because the wood chipper will cleave a variety of proteins. It will cleave fibrin, fibrinogen. Our wood chipper will cleave Steve Buscemi if we put him into the wood chipper. And we get a variety of products specific to what goes into the wood chipper. This is useful because we can tell based off of the degradation products what went into the wood chipper in the first place. For example, if we see a spleen, we can confidently say that that spleen belongs to Steve Buscemi. So when we see a D-dimer, we can say that it came from fibrin that was produced by the coagulation engine, whether it's a DVT, a PE, or from injuries. Importantly, D-dimer is not equal to fibrinogen split products, which we can get from the activation of the wood chipper without activation of the coagulation engine. Now that we know what goes on inside the wood chipper and what comes out the other end, what we need to know now is how the body turns off the wood chipper. If we go through the mechanism, we can find the places where this occurs. As TPA activates plasminogen into plasmin, we see the two main locations that the body turns off the chipper, through inhibition of TPA and plasmin. We can correlate this to turning off the switch and breaking the teeth. First, let's talk about turning off the switch. This is accomplished with plasminogen activation inhibitor 1, or PI1. PI1 binds to TPA and renders it unable to activate plasminogen. Plasminogen just bounces off of TPA without being converted into plasmin. The next way that the body inhibits the wood chipper is through the breaking of the teeth. This occurs through the action of alpha-2 antiplasmin, or alpha-2 plasmin inhibitor. After TPA activates plasminogen into plasmin, ultimately this plasmin will remove all of the fibrin of this system. We do not need active plasmin when there's no fibrin, because plasmin can cleave multiple different products. So we need to get rid of this unbound plasmin. And the way that we do that is with alpha-2 antiplasmin. Alpha-2 antiplasmin binds to plasmin that is not bound to fibrin and cleaves it, rendering it unable to cleave other proteins. Thus, the two mechanisms that the body has for inhibiting fibrinolysis are through turning off the switch in Pi1 and breaking the teeth in alpha-2 antiplasmin. What happens when these inhibitors are not enough? We have an unregulated fibrinolysis and the inability to form a stable clot. Ultimately, we bleed out. Where we see this is in trauma. In trauma, there is a loss of Pi1. Without Pi1, we lose the ability to turn off the switch, rendering TPA constitutively active. This leads to an excess amount of plasmin and the inability to form a stable clot. So, if in these traumas the body loses its ability to turn off the chipper, how do we augment the system? How do we turn off fibrinolysis? We do this with the antifibrinolytics. The two main classes of antifibrinolytics are the serpins and the lysine analogs. The serpins, or serine protease inhibitors, are a class of drugs that bind to and inhibit plasmin directly. The most well-known of these is aprotonin. However, it was removed from the market in 2007 due to an increased risk of death due to MI. Fortunately, we have the lysine analogs. The most well-known of these are tranexamic acid, TXA, and aminocroproic acid, or Amicar. We can think of the lysine analogs as soluble Velcro. If you recall, the Velcro hooks on the fibrin are actually lysine residues, and thus the lysine analogs are a soluble form of lysine. These drugs bind to the lysine binding sites of plasminogen, preventing it from localizing to fibrin, ultimately preventing its conversion to plasmin. So how does the use of antifibrinolytics play out in the clinical realm? One important study was the MATTERS study, which looked retrospectively at over 800 war-injured patients and the effect of TXA on their outcomes. This study showed that TXA decreases overall mortality. On the y-axis, we have cumulative survival as a fraction, and on the x-axis, we have follow-up in days. The solid line represents patients who did not receive TXA, and the dashed line represents those who did receive TXA. If we follow both of these lines out to 30 days, we see that there is an absolute survival difference of 15%. Death is not the only outcome measure that we look at in orthopedics. Thus, one of the questions that we should be asking is, do these antifibrinolytics reduce transfusion rates in orthopedics? The short answer is yes. This study reviewed 43 randomized controlled trials on antifibrinolytics in orthopedic procedures, and the majority of them showed a significant reduction in blood transfusion rates with TXA, particularly in total knee arthroplasty, total hip arthroplasty, spine surgeries, and other major orthopedic surgeries. However, the major limitation of this review was that safety was not investigated. If we block fibrinolysis, we would therefore expect thrombosis. Enter CRASH 2 to answer this question. CRASH 2 was a huge study that took 20,000 patients from over 40 hospitals around the world and randomized them into a TXA group and a placebo group. It found that there was an overall decrease in the risk of death due to any cause, and in particular, there was a decrease in the risk of death due to bleeding, with a relative risk of 0.85. What was really important in this study was that there was no significant difference between the TXA and placebo groups in terms of vascular occlusive events. Specifically, the relative risk for any vascular occlusive event was 0.84. Thus, we can confidently say about antifibrinolytics that they decrease morbidity and mortality in surgical patients, according to the data, does not cause thrombosis, and no other intervention has had a greater improvement in reducing blood loss in surgical and trauma patients. A comparison of the efficacy of tranexamic acid versus aminocaproic acid in reducing blood loss in corrective spinal surgery is currently underway. Oral TXA is also being investigated. Imagine giving patients a pill pre-op that limits their intra-op blood loss. At this point, we have discussed all the major aspects of intravascular fibrinolysis. However, fibrin is deposited both intravascularly and extravascularly, with the majority of it being extravascular. Thus, we need another chipper in the extravascular space. And while we need the intravascular chipper to prevent thrombosis, we need the extravascular one for healing. To solidify this notion of intravascular and extravascular fibrin deposition, we have this time-lapse depiction. In dark green is fibrinogen and light green is fibrin, with orange being platelets. Here we see the majority of the light green fibrin being deposited outside the vessel. Thus, we need another chipper in the extravascular space in order to remove fibrin in both locations. While we need the intravascular chipper to prevent thrombosis, we need the extravascular chipper for healing. The Schenneker lab recently showed that fibrinolysis is essential for fracture repair, for healing in the extravascular space. In this study, the lab looked at plasminogen-deficient mice essentially without a fibrinolytic system, and were able to show that these mice were unable to heal their fractures. A more common example of fibrinolysis in the extravascular space is in diabetic patients. Fibrinolysis is deficient in diabetics for many reasons, some of which we are still trying to figure out. But because of their deficiency in extravascular fibrinolysis, they do not heal, and thus we see things like diabetic foot ulcers. So how does this extravascular fibrinolysis work? In the same way, through complexes. If we take a look at extravascular cells, we first have plasminogen that gets activated to plasmin. We then have a UPAR-UPA complex which binds to the surface of injured extravascular cells and acts as the activator. Finally, we have the damaged cell itself, which acts as the Velcro, bringing the plasminogen and our activator into close proximity. If we look inside the vessel and look towards the extravascular space, we see that we have injured extravascular cells expressing the Velcro. The injured cells also express UPAR, which binds UPA and acts as the activator. This activator converts plasminogen into plasmin. which can break down fibrin in the extravascular space and promote wound healing. At this point, you now know everything about how the coagulation engine lays down fibrin and how our two wood chippers remove fibrin from the intravascular and extravascular space and what the products are. But what we don't know is how these two systems talk to each other. Imagine a situation where both of these systems were on at the same time. When we have an injury, fibrin would be removed at the same time it was being laid down. This would lead to uncontrollable hemorrhage. There has to be a way that these systems communicate with one another. What we need is for the coagulation engine to lay down fibrin to a sufficient level to where we achieve hemostasis. Once the hemostasis is achieved, we need the fibrinolytic wood chipper to break down this fibrin in order to promote healing. So how does the body do this? This is accomplished with TAFI, thrombin activatable fibrinolysis inhibitor. TAFI starts out as an inactive zymogen and is activated with the generation of thrombin by the coagulation engine. If you recall, the fibrin velcro is made up of lysine residues. Activated TAFI is then able to cleave off lysine residues, removing fibrin's ability to bind TPA and plasminogen. So if we take a look at the systems level, we see how when we have activation of the coagulation engine, thrombin is generated. This thrombin activates TAFI into its active form. TAFI is then able to inhibit the wood chipper by removing the lysine residues. This allows for the coagulation engine to build up enough fibrin to achieve hemostasis. Once hemostasis is achieved, the thrombin decreases, decreasing the amount of activated TAFI, thus activating the fibrinolysis wood chipper, allowing for fibrin to be broken down into fibrin split products. Now you have all of the information to fully understand the buildup of fibrin, the breakdown of fibrin, and the communication between these two systems.